On Nigeria Today, we will look at the implementation of the 2030 targets of SDGs, primary healthcare, challenges and prospects. Thanks for joining us. I am Ikaria Clinton, and this is Nigeria Today. Now joining us in the studio for the conversation is Dr. Muyi Aina. He's Executive Director, National Primary Health Care Development Agency. It's good to have you in Nigeria Today.
Good evening, Eukaria.
And also with us here in the studio is Dr. Isaac Akume Ebuja. He's a public health specialist. You're welcome to Nigeria Today.
My pleasure. Good evening.
I'll start with you, Dr. Muyi. Now, can you tell us, of course, having had the introduction, we're talking about the SDG achieving the target, what is the current state of the primary healthcare system in Nigeria?
Thank you. I think good question, but I would like to draw a line between what was the state about a year plus ago when the government came in and what I think is the state now. I think undoubtedly there were a lot of challenges and still are a lot of challenges with the primary healthcare system. We have a lot of primary health centers. Most people know some around them, but many are not at the level of quality that you require to provide the basic services for Nigerians. However, I have to say that over the last 1 year, with the commitment, leadership, and investment of President Bola Ahmed Tinubu, and the direction of Minister Mohammed Adipate, the Coordinating Minister for Health and Social Welfare, I think we have recorded some progress. We set out to do a number of things. One is to revitalize the primary health centers, meaning you start to rebuild them to make the infrastructure dignified enough and decent enough that people feel safe to go in there to receive care, to have health workers that are skilled and know what they're doing, to have equipment, to have drugs and commodities, and to have power so that they can at least run 24 hours and have accommodation in some instances for the health workers. As of today, over the last year, about 280 primary health centers have been upgraded to that standard, and there are, believe it or not, another 3,700 or so that are in the pipeline from different funding sources. Some of that directly financed by federal government, many of that being done by states with their money, and quite a few also being done by partners being done by government through donor money. What we are focusing on is not creating new facilities, but revamping existing ones to level of quality that are good, because what we find is we have many new buildings that don't have the engine to work. So there's been some progress there. This week is the week of the joint annual review, where we are coming together as stakeholders, federal government, state government, to look at these goals and how we have moved, what we have achieved. And there's some progress in terms of, if you look at the number of people accessing services in these basic healthcare provision facilities, if you look at even some of the outcomes, the quality of care measures, they're starting to look better. And there was a perception index also. There was a survey that was done that is a client opinion survey, that we commissioned. When you compare it to when we came in, there's improvement. Nigerians are a bit more hopeful in the quality of care that they will get.
Okay, still on the some of the challenges. Now, can you please tell us some of the significant, the challenges you face in making significant development, especially at the grassroots?
I think the first one is a limitation in resource. When you're coming from a low base, when we came in, even out of the 8,400 facilities that you mentioned that are funded by the Basic Healthcare Provision Fund, only 1/5 had the basics that it needed to reliably provide care for people. If you're going to fill the gap for the remaining 80%, 81%, that's a lot of resources to hire people, to buy equipment, to fix, old buildings. So the first thing was resources. But fortunately, the president really put his money where his mouth is. He promised Nigerians better health care, and he invested in health care. The health care appropriation for 2024 tripled what it was in the previous year, and that trickled down. That's for the health sector, you know, and that trickled down to the primary health care system. At NPHD, our capital budget went up significantly. So that has given us some resource to be able to do more than we typically would have been able to do, at least, you know, in Naira terms. So I think that is the first thing. The second thing is the issue of human resources. You know, if you give me a lot of money, I can build buildings, I can buy equipment, I can even buy drugs, but I can't really manufacture people, so especially skilled people. So what we found is that there is a shortage of healthcare workers given the migration of people. So government has also taken steps to stem that. By one, we're focusing on some of those enablers that allow health workers to want to stay even in underserved rural areas. So we're giving them accommodation to stay, we're making sure there's all-around power, we're providing security, and also giving them the work tools so that they can be fulfilled in what they're doing in these primary health centers. Of course, in all of this, when I say we were working with the states, the federal government, at least at the national level, does not operate facilities, but we invest in facilities, but that's working with the states and local governments. That's already yielding fruits, because many states have now really moved in the direction of absorbing healthcare workers that were either doing volunteers or not working. You know, as we're revitalizing facilities, we're requiring them to staff them up, and we see some traction with that at the state level. The third thing is the issue of trust. So you can provide the supplies when you fix all of the inputs. But over the years, because if we're going to be fair, the primary healthcare system has not necessarily delivered for people what they expected. So the trust has kind of waned, you know. So in trying to rebuild that trust, you know, is also quite a challenge, and having people come and access the services. There's that will to access the service. There's also the wherewithal in terms of ability to transport yourself and pay, you know, your way through there. So we're also working on that through communication and engagement. Just this week, we unveiled a website, sort of a tool where you can go online and check the state of the facilities near you, wherever you are in this country. You can search by location, or you can just search by, you know, PHCs near me. You can identify the facilities, you know what services are available, you know what to expect when you get there. And you can also give us feedback so that we know, you know, sitting in our offices in Abuja and wherever else, you can't see every corner of Nigeria. Primary health centers are in every corner of Nigeria. So we're taking steps to try to engage people and give us feedback. Some of it we will like, some of it will not make us very happy, but if it's the truth, it will inform our response and what we do.
Thank you very much, Dr. Muyi. Now to you, Dr. Isaac. Now, the Executive Director, of course, told us about what steps or how they've come a long way and what progress have been made so far. Now, you've been in the health sector for a while. Now, tell us, how effective has the Nigerian's primary healthcare system been?
I think what Dr. Muyi said is very important. At some point in time, we were doing very well, and at some point in time, too, we were not doing as expected. But the good news is that there is this renewed determination to make things work, especially the area of partnership between the center, the subnationals, and the local government people, because if the federal government is providing support at the central level, it cannot go and implement practically. It has to go through the states. The states also have to go through the local government. And the local governments also have to partner with the communities. So that issue of partnership, which is being revisited, is very key, very important, because everybody needs to take ownership of whatever is going on. If the federal government is providing policies and guidelines and some resources, those resources have to be complemented by those from the states and from the local governments. And hopefully, now that the local governments are becoming autonomous, it would help for them to be able to provide the staff that is needed. It's one thing to have physical structures, like Dr. just mentioned, and to have materials. Materials here, I mean medical equipment, basic medical equipment, for example, for deliveries. And it is another thing to have a skilled health worker who would use those equipment. If you have a fancy building, nice equipment, but no skilled or well-trained health worker, then you've not achieved anything. So the effort of revamping primary health care has to use, first of all, the human resource. We need to train more people. And I'm glad that Dr. just mentioned they are training. We don't have enough. But as long as we are constantly training new people and retraining those who are already in the system, we will get better and better. Then, of course, the material resources that we need, drugs, equipment, and infrastructure, in the physical infrastructure of the health facilities that we're talking about, is very key. Some of them wear down very quickly. They have to be well maintained. And of course, some of them need to be replaced, replenished from time to time, especially drugs. Okay. Then the last, of course, is financial resources, which is also very important. I am glad, and I agree with Doctor. I have been monitoring health budget in the last few years. If you go back as far back as 10 years ago, 11 years ago, and see what we used to have, 2%, 3% budgeted for health out of national health budget, especially at national level, it was very discouraging. More so because not every amount of money budgeted or appropriated was released. It's one thing to have a budget. It's another thing to really provide the money. So now that it is improving, it's good news. Then the other very important news is the National Health Insurance Scheme. More people are getting into the system, which is very important. Many states are being sensitized now to participate in the National Health Insurance System, which is very important. And I think as we encourage local governments to be autonomous, they would be able to enroll their own staff to be part of the system, so that the multiply effect will not only be felt at the central level or at the state level, it will also go down to the local government level. Some time ago, we were having a discussion, and one of the things that some of us suggest is that at some communities, it is possible to organize some system of health insurance. We cannot go into that now, but that is a complementary way of enhancing primary health care delivery in the system.
Okay, thank you very much. Now back to you, Doctor. I know earlier you talked about the review that just went on or that is going on. Now, tell us, with what you have seen so far, of course, as stakeholders came together to, see how far we've gone. With what you have seen so far, how close are we to achieving the SDG, target of 2030? Talking about the SDG 3 in the health sector.
I think the data is the data. The facts are the facts. In some regards, we're on the way. In some regards, we're not on track, which is why we're trying to change what we the way our performance, along maternal mortality, but also child mortality and other associated outcomes, And to do that, one of the things that we did and really discussed at length during this week is to now say, okay, if you want to reduce the death of mothers, for example, what do? You ask, where are they dying? And then ask what is killing them, right? So we have identified about 172 local governments that account for 55%. That's more than half of maternal deaths in Nigeria. So if you are going to prioritize your resources and your effort and focus, you will agree with me that it makes sense to focus on those ones. And even within those ones, we looked at it to say, you know, are they all the same or are there differences? And when we analyzed the data, we found that there are at least 4 different subgroups. There are those where, at least relatively, there are good quality facilities, but people are not going. So that's a demand issue. Either the intent to go, people don't want to go because they don't trust the system, or they don't have money or the ability to get themselves to the facility. So insurance will solve that. Community engagement and other things will solve that. There are those where there are facilities and people are going, but women are still dying. So that's a quality of care issue, because they're accessing the care, but the care is not the right one, it's not high quality. So there are interventions that we are doing to target those. There are those where the facilities are not there, but the few that are there, people are going, you know. So for that one, that's a service readiness. You have to very quickly increase availability of the facilities. Of course, you have to do demand interventions, you have to ensure people, you have to make facilities better everywhere. But in terms of prioritizing what you do, there is a 4th category where there are no facilities and the few that are there, people are not going. So that one, everything is their problem. So that's how we have categorized it, and what we are doing next is to go with the states to engage in local government by local government to really understand on the ground what are the contextual issues, because you can sit here and analyze the information and you have a sense, you have an idea, but until you talk to the people, you go there and understand what is really going on, that's when you can then develop approaches and solutions that if it's a demand issue, if you assume that the issue is money to go to the facilities, whereas it's a cultural issue that needs to be addressed, or you can assume it's a cultural issue and you are solving that, whereas it is that they don't have access road to go to the facility. So being able to engage at that level is what will help us. We're also introducing a community-based service delivery model where we're reintroducing community health workers that will be trained and salaried and are staff of the government. For this one, we're working with the states and local governments as well. And they will, within the communities, they will provide basic services, health promotion, counseling, screening, for things that you can treat very easily using algorithms, malaria treatment using ACTs. I mean, lay people go to pharmacies and buy it. So they will be trained, certain screening tests, and then referral. But very importantly, they will also have a responsibility, at least in areas that are underserved, that are where we are, a lot of people who don't have access to care, to just register the people, register them for the health system, register them for health insurance. You understand what I'm saying? And follow up on care. If a child is born, they will be able to track the vaccination. So imagine a situation where a community health worker is assigned to 250 households. And they go there every day, every month. They are in these households. What is the probability that there will be a pregnant woman and they will not know to refer the person for antenatal care? So if we are able to deploy them and manage them closely, I think we will make progress.
Okay, I still want to take you up on the availability of facilities. You know, President Bola Tinubu's administration has promised doubling the primary health centers from 7,800 to 17,000, no, 8,800 or so, to 17,600 over the next few years. Are we on course with this?
I think we have started that journey, and I think we stand a good chance. If we continue at this trajectory, I think we stand a good chance. Like I told you, even though we had to do an assessment to understand what is going on and then mobilize resources, domestic resources from government at all levels, but also donor resources, that is our partners that want to support us in this. So we took some time before we actually got started. We are counting on a daily basis, and as of this week, we have 280 facilities that have been done. That may sound little compared to the 9,000 or so that we want to add to the base that we have, but you see, there are, even in my agency, there are about 342 or so that contracts have been awarded, that they are working on it as we speak. There's another 200 that one of our partners is working on. And then using World Bank financing, impact project across the states, there are almost 3,000 facilities that the states will revitalize using World Bank facility. Many states outside of this are also working on their own, using their own resources. Niger State is doing 100. Jigawa State, I think, was doing 63. Kogi State told me they want to do 60 something. So many states have also taken this on, but Borno State has also revitalized some. So I think Ogun State as well, I'm thinking through my head. So there are many states that have also used their money and are using their money to do more, beyond all of the ones that I'm counting. And next year again, we will get additional resources to continue. And we're also developing a framework for the private sector to come in an organized way, because government cannot do it all. You don't have to, you can do it yourself, but we want to define an approach to say, if you are going to work, this is the standard, this is what is expected of you, this is what state government will do, this is what federal government will do, and as a private investor, this is what you are going to do. And the National Assembly as well. They have a lot of constituency projects, so we are trying to organize it in a way that helps us build up the number of good quality facilities.
Okay, thank you very much. Dr. Boja, I want you to, pinpoint some areas that you think more work should be done if we are to get better health care for all Nigerians in a couple of years.
Well, even though the budget for health has increased substantially at the national level, I cannot promise or I cannot confidently say that every state is responding well with increased budget for health. And then when you budget for health, you need to prioritize, especially in the area of primary health care. Okay. So many states probably have not keyed into this spirit of trying to improve with this urgency and the speed that we would like to see, in my opinion. Secondly, there's a challenge of insecurity. A good number of states have this problem. There are many health facilities in those states that are rural communities that are affected, where people are not stable, where people are not farming, where people are not staying constantly. And more importantly, if you want to, one of the key services that you can use to assess the effectiveness of primary health care is child immunization. And when you take immunization as a service to use in assessing the rest of primary health care services, you will find that because of insecurity, for example, there's a lot of attrition. Attrition meaning a child that was born started with some antigens, BCGA and so on and so forth. But by the time that child is 9 months old and will be ready to take measles, the child has moved to some place. And that some place may not be a secured place where there are services for the child. So that's a problem. Then, of course, we all know things are getting more difficult economically in the country. People are finding it very difficult not only to physically access health facilities, but also to financial access services.
Thank you very much, and for you, Dr. Muyi, we want to get your closing thought on all of the issue.
I'd just like to speak to a couple of things that Dr. Boja mentioned. One of it is the skyrocketing cost of care, whether in terms of paying for services, but also commodities. So I think the president is well aware of that, and he's responding, in ways. And some of what we are doing as a government are, we're using pool procurement mechanisms to acquire affordable commodities and providing them at least as stock, free stock, for facilities in the BHCPF PHCs. And the idea is we'll then work with them to have a revolving mechanism to recover their costs over time, but at a subsidized rate. That's one. There's also the issue of insurance, where we're trying to drive up coverage for the vulnerable groups. One of the conversations we're having now with NHIA is to include what we call vulnerable families. So zero-dose children, to your point, you spoke about immunization, Dr. Boja. So children that have never received, any vaccines,
Thank you.
Thank
Thank you very much. Thank you. We had Dr. Muyaino. He's Executive Director, National Primary Health Development Agency. Thank you so much for your time and your contribution. And also we had Dr. Isaac Akume Ebuja, the Public Health Specialist. Thank you so much for your time
pleasure.
and your contribution. And thank you for being part of the program. I am your carrier, Clinton. Goodbye.